So then we have surgery. So here we have a limb, and we've drawn our little line down, and so this is a right front limb. Here would be the other limb. So what is this? Valgus. What? Carpal valgus. Good. So what side? Let's say this is one of the disproportionate growth ones, right? So the physis was growing faster on one side than the other. Which side, the medial side or the lateral side, was growing faster? Yeah. Okay. So we have two options. We have surgeries to try to accelerate growth, and we have surgeries to slow down growth. So this is an important principle, so make sure you're thinking through this picture here. If you have something like this, the reason it happened is that you're exactly right. The medial side was growing faster. So what you want to do is slow down the side that's growing faster, and or speed up the side that's not as fast. It works just exactly the opposite if it was varus, so if you understand the point. There's only one surgery that speeds up this. And we'll be talking about periosteal transection and elevation, also called a periosteal strip. If you spent time at any of the racecourse places, you've probably heard of it as like, this is the little strip that falls in. So periosteal transection and elevation is what it is. So you're going to perform that on the concave aspect of the limb. This is the concave aspect of the limb. The side is like curving towards, I guess, right? So think that is like concave, is like a cave that you can walk into. So you can imagine this side here, if you kept the curve of the leg and made it like super severe, it would form a cave. So that's, and some people have trouble remembering concave versus convex, that's why I'm talking about this. If you don't, ignore me. But so concave is like you're walking into a cave. All right, so convex is the other side. So this would be the concave side, this is the convex side. So periosteal transection elevation you perform on the concave side of the limb because you're trying to get it to go from like the curve here to straighten back up because you want it to be growing faster. All right, that's my little soapbox. I don't actually think the surgery does anything at all. This is one of like the most common surgeries they'll do out there in practice. They've also done studies coming from a bunch of other big surgical centers to say we took a whole bunch of holes and did nothing to them, and then we took an equal number of holes and did a periosteal transection and elevation, and they came out with exactly the same number having corrected at the end of that. So there's a lot of people that do this, they believe in it. I mean, they make a ton of money on these in the racehorse industry, the young horse industry. But there's a lot of people who think this actually doesn't do anything at all. You're not really stimulating the growth, and the horse is just naturally correcting himself, which some of them will. One reason I kind of fall more in the, I'm not really sure it does anything camp, is that you cannot overcorrect these. Now, you would think if I was really doing something that's going to make it grow faster, I could make it grow too fast, right? Like if I did this and it was really working, why wouldn't it just stop at perfectly normal? Why wouldn't it maybe in some cases make them, hyper-correct or overcorrect? But that doesn't happen for us. You can make up your own decision, different cancer and different things. We still do it sometimes, and they're very easy. The outpatient procedure, you just quickly lay them down, do your little transection elevation, wrap them up, send them home. So this is how it's done. Just look at this little part right here. It's really just what I'm trying to show you. Again, I have this up here so that you understand what the transection elevation is. I don't need you to know the actual surgical procedure. But so this is where you're going to be going, and I just have these labels so that you can see what they are. So you see this right here where it's a little like slit and pulled up. So all you'll do is make your little approach, go through the skin, dissect down, get right to the bone, make a T-shaped incision on that periosteum, and take a little elevator and just flap those little things up. So they're kind of pulled back here and just flapped away. Then you lay them back down, put a couple sutures in, knock them up and down. That's all it really is. Okay, so these are obviously people that did believe this worked. So here you go. Here's a carpal valgus and a 2-week-old warm blood foal, left forelimb. They did a periosteal transection elevation on what side? This side or this side? Concave. So, yep, lateral right here. And then, here he looks wonderful and perfect. So either he corrected himself or the surgeon did it.
you ever have to worry about like a spectrum forming?
Not that I've heard of or seen reported or experienced. I mean, I would say it's completely impossible. I can see why you're thinking that, because anytime you start periosteum, but the periosteum's still there, because you laid it back down. I've just never heard of it. So, not a big worry.
So what exactly do they think causes the acceleration of growth, just by cutting?
It's like stimulating it, you know, it's like cutting it, now it's angry, it's like, oh, I have to wake up and grow. So that's the idea. Or, you know, I wonder if this is like light shadow there. Okay, here's actually, now that I look closer. All right, so I think this is the white right here, and this is like shadow. But that's maybe stretching it, I guess. Well, this is, I mean, like I told you, I don't know how this works, so you just pretend it's the same horse if you don't think it is. But here, there's a little bit of dark right there, a little bit of dark right there. I don't know. It's not going to make a difference. Here's the other kind of reason I have my suspicions about this surgery is because they a couple years ago were presenting at conferences not the technique of actually cutting the periosteum and like flattening it up like I just showed you, but there's some places that are like, oh, you don't even need to do that. All you do is put a needle, you don't even cut the skin, and like wiggle it around a little bit, and ooh, that worked too. All right, so growth retardation. This is the opposite. That was your one surgery to try to accelerate growth. This is everything else. All right. When you're going to do this, when you think you have a foal that really needs something faster, you don't think you have the time to mess around on a surgery that may not work, or you really, you see quite a deviation, you're like, oh, we got to get to this before it's too late. And the second point is older foals after the rapid growth phase is over. What are both of these surgeries working on? Growth, right? If I do this on like a 15-year-old horse that has an ambulation, and then he's not growing anymore, right? You're working on the fact that this young horse is still growing, still getting longer, and you can affect the growth rate by one of these surgeries. I've got a slide that talks about what joints you have to do it by what month. That's super, super important. So just keep that idea right now. You have to do this when it's actually well. All right, so just the opposite of the other one, implants applied to the convex side, so you're going to slow down the growth on that side. A few different ways. Here is a staple. So here's the physis photo. Here's a staple, and you just put the staple right on either side of the physis. The idea is that it's locking that physis down so it can't expand, while the other side is still allowed to expand. Okay, so that's one way. This is two screws just placed horizontal approximately to the physis, which is right here, and a little bit of wire in between. Same idea, just locks them in. And this is a transphyseal screw. Okay, so probably the most common way we do it nowadays is the transphyseal screw. So you're just making one stab hole here, or one stab incision, and radiographically guided, placing your screw through the physis, and making sure you don't hit the joint. I think I've got an individual slide.
Sorry if you already said this, but once you do that, you get the adequate growth, then you just pull it out.
Absolutely, yeah. What would you be worried about if it stayed there?
Infection or growing around it.
If you go the opposite way, the overcorrect.
Yeah, you can overcorrect.
Oh, okay.
Yeah, exactly. But yeah, so if you forget about that screw, send it home, the client's like, hey, it's perfect, I'm never going to bring it back, and he goes out and back for it, and you see him a year later, oh, he's going to have gone the other way. So this is just what I showed. This one's a staple. You see the blue here is the physis. Here's your screw and wire. Here's your, you can do a plate. And here's a transphyseal screw. So posterior physis, you get the idea. You're just locking in that side of the physis. Cosmetics is better with this because you have less stuff under the skin. So you get less kind of bony proliferation. It's less obvious. There's only one little incision, so anytime you do this, you have the chance of white hairs growing. Just like I think you put on a small animal, right? But horses like to make white hairs when you do surgery. So less obvious that you will have done something. there is a little bit of a risk because you're putting this screw in, you know, not in a straight plane, you're putting it kind of angled. You want to be really careful, especially when you go to take that screw out, but you don't pop the head off the screw because it's under a lot of stress because it's a tight angle. Again, this is just to explain how it happens, we're not gonna touch on it. So, a lot of times we put a needle into the joint just so we can know exactly where we don't want to drill past. Make your little incision up here. You start out just to get purchase in the bone, going in straight, and as soon as you're in, you angle your drill, you know, much closer plane to the bone, and then you're gonna just drill until you're through the physis there. You will take a radiograph, make sure you're where you want to be, and then measure what length of screw you want. You know, so you definitely don't want to put your screw or put your drill, or especially your screw, down here into the joint. Big problems. So the screw and the wire, these are really severe. Look at these guys here. So one in the center of the epiphysis and one proximal to the physis, just one on either side of the physis there. And then any of these things where you're putting metal in can absolutely overcorrect. This is what I have faith that I'm actually doing something. Cosmetics, a little bit less good than you know, with your periosteal strip or with your just transficular strip. Okay. So this is just from the AO website. So this is what we had to begin with. And I'm guessing they're you know, with the ankle here, I think it's a little hard to tell because you're not looking exactly straight, but I think they're thinking this is a fetlock Paris based on the fact that we have the radiograph, you can kind of see the line here and then it turns that way. If this was straighter, maybe I think you could tell that it wasn't the tarsus in this case, I guess. All right. And so after correction, this is the appearance. They used a screw and wire technique and left it in for about 6 weeks. Kept checking that fold for the moment that he looked perfect, and then pulled the screw and wire. So you can see here there's kind of a bump on the outside of the fetlock. That may resolve a little bit over time. I don't know if this is before or after removal. It's probably before removal. But you know, you can get that bony bump there, but it will resolve a little bit after the removal.
Is it possible that, like, if you were to do it, they straighten up, you remove the screw, and they keep growing, can it still start messing up again?
Yeah. Well, so sometimes what can happen is that you almost spot weld the physis. So once that screw's out, it's still, I don't know, it may overcorrect a little bit. Some people try to remove them a little bit early with that idea. It's always a little bit of a fake.
Once you add the screws, do you need to put something over it, like bandaging or anything like that?
Not long term. So once you put your screws of any sort in, you'll suture it. There's really not a whole lot to close it. They just suture the skin over the screw head. Bandage it for a little bit. Just treat it like a healing wound. And then, you know, after the first couple weeks or something like that, you can take the bandage off, and then he just grows. And then when you take him out again, you just let bandage again. There's no big heavy bandaging with all right. Well, there's some, but you know, it's just try to avoid that unless there's a problem. All right, so this is my be careful. So this is a fold that had transfacial bridge is what they're trying to say here, this with the screw and wire here. So he was originally a carpal valgus, right? And I guess 5 months after surgery, the foal had developed carpal varus. Did I say that right? So carpal valgus to start with, and then oops, carpal varus. So you won't usually have to wait as long as 5 months, so I think this was just ignored. Okay, so I don't need you to know a lot about this. I just want you to understand the principle, what corrective ostectomy is. So remember, all the stuff we were talking about was based on the fact that the foal is still growing, the young horse is still growing. Now, what happens if they bring you something that's past the growth phase? Here's your only option. Do we do this often? We do. But this is what you're left with when the horse is not growing anymore. So if you're unable to utilize limb growth to achieve normal ambulation, or when you have something rotational, instead of an angular limb deformity, you've got like something that like rotates this way, Usually you're talking about the cannon bone, doing something on there. But what you're gonna do is remove a little, make a couple of cuts through the actual bone, remove a little wedge, and then slide this piece of bone, towards midline. And it's pretty dramatic when you're cutting cannon bone, right? I mean, that's like a big fracture repair. If this is a fracture repair, and of course you're talking multiple thousands of dollars when you have the cannon bone, and this is the same deal. So this is not something, I've never actually done one of these in my career. I just want you to understand, like, this is something that you would be your only resort if you were trying to fix something after the growth phase is done. Okay, so just another little chart that can be useful for studying when you have, different types of stuff. Here's treatment techniques. Remember that saying about the fetlock? So fetlock, you have to get to these guys really, really quickly. The fetlock growth plates will stop rapid growth. Here we go. So distal metatarsus, the rapid growth before 100 days or so, and they radiographically are fully closed from 6 months to 15 months. So think about when you have to act on these fetlock before 2 to 3 months old. So 3 months old, that's like 90 days, right? So we want to be acting during this period of rapid growth. So if you have a fetlock and this thing is like, let's say 7 weeks old, you are not, and it's got a decent amount of deviation. You're not going to be like, let's put him in a stall, I'll check him in 3 weeks, we'll see how he's doing. With fetlock, you have to act really soon, okay? With tibia and radius, you have a little bit more time. So tibia, you want to get to them before 4 months old, radius before 6 months old. You can see the distance, between the period of rapid growth, distal radius, which is those carpal bears, is about 8 months, right, versus like 3 months for fetlock. So you have more time for the radius and tibia. Don't mess with the fetlock. Get another 9 months. 3? Any questions on angular limb? So let's just start with flexural limb, and then we'll pick this up, I guess, on Monday. All right, so we talked about angular limb deformity, like this way or this way, and now we're talking about this or this. So deviations in the sagittal plane, if you don't understand. So we have hyperextension, like this, or you can have hyperflexion, of a couple different sorts. What is that? So, in order to know what abnormal looks like, especially with this, you've got to remember what normal looks like. That seems obvious until I show you pictures of abnormal and ask you where the problem is. So, remember when we have a normal horse, here's the cannon bone coming down, there's a normal change of angle at the fetlock. So this is normal for it to be quote-unquote hyperextended. That's just what the fetlock looks like. So coming down straight, and then I turn. Now once I turn, I want a straight line. Remember that hoof pastern axis? This is fairly normal here. So you can imagine, pretend this is like an exactly straight line. It's a little bit off, teeny weeny bit, but it's not bad. So this should be a straight line, okay? So through the long pastern, through the short pastern, and through the coffin bone. We'll take 1 second to address terminology. So we hear a lot contracted tendons. I will probably say at some point in this lecture, contracted tendons. Now, truthfully, the anatomical and physical basis of this stuff is usually not that the tendon is actually contracted. You can have those cases with an actual contraction of the tendon, but they're more rare. All right. Usually, what you have is you have a bony column coming down, and then you have, let's say, the flexor tendon column coming down. So, pretend you're a horse's leg. So, bony column here, and then all the flexor tendons are on the back, right? So think about it as like two things like this. So the bony column and the tendons. Now, ideally, they're the same length, right, to make a normal appearance of a horse. Now, what you often have is the bony column grows faster than the tendon or ligament column. So you end up with a relative short. So these are my tendon ligaments. They're not primarily contracted. It was like these were normal, and then the bones grew faster. So the tendons, which are still attached, were pulling in a weird direction. Does that make sense? Everyone, you can see that? All right. So contracted tendons, they can happen, you know, if you have a tendon injury, that sort of thing, they can contract in, but it's not usually what we talk about. We'll try to avoid this term, sometimes they slip, you know, we talk about contracted tendons, but usually that's not what's going on. So hyperextension, there's very little I'm going to talk about on this because this is not a huge deal. Alright, so hyperextension, this guy right here. Remember that laxity of the periatric structures we talked about in angular deformity, where the lateral ligaments are just too floppy and they kind of angulate? It's pretty common for folds to come out with these really flexible, lax tendons and ligaments. Oftentimes, over the first couple weeks, these just resolve themselves. These foals get a little bit of exercise, you know, like here, these guys are allowed out on the pasture. They need that exercise, and they're, over the first couple weeks, just going to go back to normal. And it's not a huge deal. Sometimes if you have a severe one, you can glue these little shoes on, which will have the result of, you know, pushing against the ground here and making this foal's toe have to come down because the heel can't sink as far as it would without the extension on. So, you know, this kind of like, you know, keep it from being able to do that little flip up because this thing is sitting here preventing it from being able to do that. If they're really close to the ground, you can put a really light bandage on, just to make sure you're not rubbing the skin of the back of the pastern or fell off. Very, very careful with your NSAIDs maybe. But usually a couple weeks, just take care of them, make sure they don't develop any other problems. They're just going to grow out. So, am I going to put a big heavy bandage on these guys? You see this a lot actually. Am I going to put a big heavy bandage that makes the foal look normal? No. Why? Because when you take that bandage off, it's going to be floppier than it ever was before. Okay? So when you need something like to firm up the ligaments and tendons, don't put the heavy bandage on. Okay? I've seen multiple of these at like thoroughbred breeding facilities. They're like, we've been bandaging this foal for the first few weeks and he's just not getting better. You know, we've been locking him up. So don't lock them up.